Welcome to OncoPharm. I'm your host, John Bazar. I am a professor of pharmacy practice here at the supporting sponsor of OncoPharm, ETSU's Bill Gatton College of Pharmacy. It is Thanksgiving week, 2025, here in the United States. I listen to a lot of podcasts. A lot of these podcasts, they kind of cop out around the holidays. They're like a mailbag episode that, is of maybe limited interest to some people. We're not doing that this week. We got a lot to talk about because for the last 3 weeks, we've been doing a mini-series on the different pathways to becoming, some of the 3 different pathways to becoming an oncology pharmacist. Thanks to Kelly Karlstrom and her ELO collaborative for supporting that mini-series. If you are interested in purchasing that course, please click on the link in the prior episodes to help support the podcast. But in those 3 weeks of doing this mini-series, there's a lot that's happened in oncology. I don't know if FDA if they were working through the shutdown and then they just word vomited approval vomited a whole bunch of approvals this month, but we got a lot to talk about. Probably go 25, 30 minutes. So if you're walking through the airport right now, or you're on that, that car drive to your in-laws, put the kids to sleep while they listen to the soothing tones of this podcast. Let's start with the BlenRep REMS program. Before, probably a month ago, we talked about the return from the grave of belantamab mafodotin for relapsed refractory multiple myeloma. That reapproval of belantamab. And at the time, the REMS program, we knew there would be one, but the components weren't not ready yet. Okay, so we do have the REMS program now. It's pretty extensive, more extensive than I thought it was going to be. So there, of course, is the prescriber registration where they look at some slides, take a test, fax the test results in. I don't know, there's not an online option for the test. You fax the results in, I guess. Then the prescriber gets registered. They can prescribe it. Patients have to be registered. Healthcare settings have to register. Wholesalers and distributors have to be registered, and they have to train their staff on who they can deliver belantamab mafodotin to. There is a patient enrollment form. There is an initial eye examination form that has to be completed, and there's an I form, EYE form, that a patient status form that has to be completed before each dose, and you get an authorization number. That authorization number is good for 28 days for the initial evaluation, then only for 10 days for subsequent doses. So that authorization number has to be obtained. So they have to go to their eye doctor, optometrist, ophthalmologist. There's a special form that eye provider has to fill out. Then that has to be faxed back or go into the EHR back to the medical oncologist office or the dispensing office. Then someone at the office has to get an authorization number before it can be dispensed. Now, I'm not sure if that means the pharmacist can't dispense it until they have the authorization number, or they can actually purchase it from the distributor until they have that authorization number. Logistically, it's going to be a burden. It's going to be a huge burden to use this. And this was, of course, in the setting of relapsed refractory myeloma. At the same time, later, I think next week at ASH, we are going to see the presentation of Majestic 3, which is teclistamab and daratumumab in a similar setting, which is, in this study, Majestic 3 is compared to Dara, Pomdex, or Dara Velcadex. A study of over 500 patients. The abstract is out. The 36-month, so 3-year progression-free survival rate is 83.4% with Tec-Dara versus 29.7% with a Dara-based second-line regimen. That's a hazard ratio disease-free survival point estimate of 0.17. The 95% confidence interval is 0.12 to 0.23. It's infinitesimal. It's so tiny, that number. So huge benefit from this. Everyone is shocked at how beneficial this is. Easily going to be adapted in this space in myeloma, and of course the logistic burden, and rightfully so maybe because of the eye toxicity of BlenRep, of belantamab mafodotin, is going to make it. I think a lot of people are reluctant to use that. And using belantamab mafodotin. So if you are going to use it, like I said before, get to know your eye doctors. Okay, another update that I missed somehow, and I follow this stuff pretty closely, I consider myself kind of a patient advocate for this, is in early October, the FDA changed the label for capecitabine. They didn't, and maybe this was during the shutdown, I didn't get an email about it. Usually I get emails for label changes, for safety changes for these drugs. I didn't get it. I saw some people talking about it on LinkedIn. I actually looked at it up, and I was like, well, I don't see the capecitabine labels change, but it did change. And the boxed warning and warnings precaution says to test patients for DPYD before initiation unless urgent initiation is necessary. So there's not an FDA-approved test for DPYD or DPD deficiency, but it is in the label to test for it. And many people would consider the FDA-approved label the legal standard. So we're testing for this. If we're testing for capecitabine, it makes sense to test for 5-FU as well. So I think this is a big win for patient safety advocates for DPD deficiency. So job well done all, and no more pre-contemplation of doing this. It's something that we need to be doing. Okay, now into a long list of FDA approvals. Some of these FDA approvals are based off studies we have already talked about. So I'm going to talk about them in various amounts of times on that. So we had the daratumumab and the daratumumab hyaluronidase approval for high-risk smoldering myeloma. This is based on the AQUILA study. I think this was ASH last year. This shows for high-risk smoldering myeloma an increase in progression-free survival with daratumumab versus no daratumumab versus nothing versus observation. And there's a suggestion that there's overall survival benefit, and maybe it's even statistically significant. I can't remember what their stat analysis plan was. A lot of people have critiqued this approach because, the observation arm, when they progress, they probably should be getting quads. But there were even low rates of getting VRD, lenalidomide, bortezomib, dex, kind of the old triplet standard of care. Only 20% got VRD, and only 18% got a CD38-based regimen. So this is a trope like a trope in rom-coms is the meet cute. Oh, funny meeting you here. A trope in oncology studies is a control arm that is substandard, below the standard of care. That seems to be the case here in the observation. I will post a critique to this in the show notes. Some folks have argued, I think with a lot of great points, that, hey, if you monitor these folks like hawks for high-risk smoldering myeloma and start great myeloma treatment, there's probably no benefit to using DARA up front as far as things that affect patients, because most of the progression events in this AQUILA study were lab abnormalities. Other people have pushed back saying, listen, following these folks like hawks, yeah, that you might not see a difference if you're able to do that. But logistically, in the real world, that can be hard to do for certain patients. And I think they walk through that nicely in this critique, which will be in the show notes. We have a pertuzumab biosimilar that's approved. It's called Poherdy, Poherdy, Poherdy. We have an approval for Epcoritamab with RR, so that's Revlimid Rituxan, for relapsed refractory follicular lymphoma. Epcoritamab had an accelerated approval in basically the third-line setting. That was converted to a regular approval with this data. So this is Epcor FL1. This has not been published. This has not been presented at a national meeting that I can find. And this is a study of patients getting RR. So that's 20 milligrams, days 1 to 21 of a 28-day cycle with lenalidomide, sort of indefinitely. Rituximab weekly for a week, then every 20 days for the next 5 for cycles 2 to 5. So you're only getting rituximab for a limited duration of time, compared to the same RR plus Epcoritamab for 12 cycles. And what you see here is a robust improvement in progression-free survival, point estimate of 0.21, hazard ratio, 95% confidence interval, 0.13 to 0.33. Impressive, not as impressive as Majestic 3 data with Tech Dara, but still impressive. Now, if you look at the curve, so this is where you look at the point estimate, you really got to look at the curves, right? The picture tells a story. If you look at the Kaplan-Meier curve for progression-free survival, which is, should have some correlation with overall survival, but the way you treat these follicular lymphoma patients is you give them BR in the first-line setting, bendamustine, rituximab, bendamustine, obinutuzumab, or if you're old-fashioned, R-CHOP or RCVP or O-CHOP, okay? And then you give them 6 cycles, their lymphoma melts away, and then it comes back, and sometimes it comes back 2 years later, sometimes it comes back 8 years later, and then you can potentially retreat with the same regimen, and it wouldn't come back again. You could do RR in the second-line setting, right? You could do bendamustine if they didn't have bendamustine before. So that's kind of the treatment approach here. So I think RR is a reasonable control, but what you see here is these folks getting RR, their Kaplan-Meier curve drops off like a waterfall between 6 and 9 months, which is about a couple months after they stop the rituximab, while the other group was getting Epcoritamab. So there certainly is some benefit here. It'll be interesting to read the publication for this to see what the there are more toxicity obviously in the Epcoritamab arm. Decent rates of cytokine release syndrome, more infections, more cytopenias. So interesting to see what the overall survival curves look like for this when this eventually is published. Okay, the next approval to talk about is Ziftomenib, which is Komzifti, which is a nifty drug name. This is a menin inhibitor. So this is another menin inhibitor. We had Revumenib that's approved. So this is for relapsed refractory NPM1 mutated AML. This is based off of about 112 patients, complete response with incomplete hematologic recovery in just over 21%. Not huge numbers, sort of like Revumenib. This is not an accelerated approval. And I had to go back and look at the Revumenib data. It was also not an accelerated approval, even though it's just surrogate endpoint data of response rate, which is a little unusual because we don't see that for other TKIs that are approved based on response rate. There is a box warning for differentiation syndrome, as you might expect, similar. There are, a lot of drug-drug interactions with strong and moderate 3A4 inhibitors, strong and moderate 3A4 inducers. Acid suppressives like PPIs and H2 blockers are called out because of decreased absorption of the drug. There's QT prolongation that has to be worried about. Even dexamethasone, which is a weak 3A4 inducer, is estimated to decrease the exposure by 40% of this drug. So lots of drug interactions to worry about, something to consider. Revumenib also has a lot of drug-drug interactions as well. And the last, I think, new drug to talk about is Sevabertinib, which is HER2 or ERB-B2. So HER2 is the protein, ERB-B2 is the gene. Tyrosine kinase domain mutation in non-small cell lung cancer, adeno, so non-squamous. The brand name of this is HYRNU, HER2. That's pretty clever. This is an accelerated approval based on an overall response rate of 71% in 70 patients who were treated with systemic therapy like chemo, but not an antibody drug conjugate like trastuzumab-deruxtecan, which we know has activity in HER2 mutated, not HER2 amplified, but HER2 mutated non-small cell lung cancer. So response rate is 71%, very impressive, but we already have an established treatment in trastuzumab-deruxtecan in that space. In a smaller sample of 52 patients who had received HER2-directed therapy like antibody drug conjugates, that response rate was 38%. Impressive that there was response, but it is less than in the first-line setting. So that's probably where I would see this used more. There are lots of drug-drug interactions with 3A4 inhibitors, strong and moderate, 3A4 inducers, strong and moderate. And when I say a strong 3A4 inhibitor, it's going to increase the exposure of midazolam by 5-fold. A moderate inhibitor will increase the exposure of midazolam, which is a just pure 3A4 substrate, by 2 to 5-fold. So these are some pretty significant interactions. There's also the fact that Sevabertinib inhibits the metabolism of CYP3A4 and drug movement through B-glycoprotein. So drugs with, the label says certain substrates, so substrates that have a narrow therapeutic index. So think dabigatran, which has its exposure go up 40% with Sevabertinib. Midazolam would go up 2-fold. So if you had someone on, say, rivaroxaban that has a mix of renal and hepatic via 3A4 elimination, you're going to have more rivaroxaban and a little bit more apixaban hanging around in somebody on Sevabertinib. So some drug-drug interactions to worry about with this TKI as well. With so much going on with this, these newer drugs, I'm not getting into some of the dosage forms and things like that. We have a couple other updates to talk about with approvals. We've talked about these before, so durvalumab in the perioperative setting with FLOT for gastric or adeno of the GE junction that's resectable. We've talked about that study. That got the formal approval. Pembrolizumab and enfortumab vedotin neoadjuvant urothelial cancer in patients who are not candidates for cisplatin, which is a lot of older folks, got a regular FDA approval after the data that we saw and talked about previously on this podcast. And then tarlatamab gets the regular approval in the second-line setting for extensive stage small cell lung cancer. We talked about that over the summer as well. What I was looking forward to was in the study that was published in NJM that established this approval and established the overall survival benefit of tarla in this setting. If you remember, they did a protocol change where the label said you have to monitor patients after the first 2 doses for 22 to 24 hours, which essentially means hospitalization. They did a protocol change in that study to 6 to 8 hours and described similar rates of CRS and ICANS, suggesting it's feasible to do an outpatient monitoring for the first 2 doses. I was eager to see if the label changed to reflect that. It did not. The label still says 22 to 24 hours monitoring after the first 2 doses, which a lot of centers will continue to follow the label, since that is, as we talked about with DPYD testing, with Xeloda, and I'm sure in the future with 5-fluorouracil, kind of what we think of as the legal standard. So that is what we have this week. I hope you all have a Thanksgiving. Furthermore, I hope it's a very happy and restful Thanksgiving. And special shout out to all the healthcare workers who will be working on Thanksgiving and over the weekend. Appreciate all that you do for our patients. And I'm thankful for all of you listening, liking, responding, all that kind of stuff. And remember, until I talk to you again, it's important to know that doses matter.